Okay, let's talk about patellar tendon repair. Again, this is not a very common surgery, I would say, but you will probably see it at least a couple times here and there. So it's good to kind of be aware of what's important to think about with patellar tendon repair. There are always going to be a couple little gems of important information that you just kind of want to remember. So our patellar tendon, it's going to attach onto the tibia from the quadriceps tendon. So all the quads come together. You have the patella then underneath, and the tendon is really from the distal part of the patella down to the tibia. And it's distal to the tibial plateau. Most of the time, the way that it happens, the way that a tear occurs or an injury occurs to the patellar tendon is during some sort of eccentric knee flexion where there's a huge amount of quadricep contraction. So the quads are contracting with the knee bent, and you're loading at the same time. Usually this is going to be landing after you've been jumping. So it's that landing from a jump. It's like a big jump. You're landing. You're trying to control your knee flexion with your quadricep muscle, and you end up with a tear of the patellar tendon. It usually occurs closer to the patella than the tibia attachment. So you can see from the picture there, it's usually right distal to the patella where you're going to get a tear. The reason it happens, it could be from a weaker tendon. And the weaker tendon can happen possibly because of inflammation. So any type of repetitive microtrauma. So any of you that have worked with me, I really do get nervous about patellar tendonitis, mostly because I worry that the tendonitis could turn into some sort of microtrauma tendinosis situation where you're getting small tears in the tendon. So I'm all about really trying to avoid patellar tendonitis with patients, after certain kinds of surgery like a patellar fracture, because I don't want that tendon to have, multiple situations of inflammation where we end up with a weaker tendon. Other things that can lead to tendon weakness, and this is true really with any of our tendons, are going to be chronic diseases, any type of rheumatoid disease like arthritis, diabetes, and chronic renal failure. So any of those kinds of things are going to lead to a weaker tendon. If they did have injections, we talked about that at the elbow with tennis elbow or epicondylitis. If they've had steroid injections because of pain, again, the reason they have pain is probably because they have some sort of tendinosis, and so they already have a weaker tendon, and then you add that injection. You add the corticosteroid in there, and it becomes even weaker. So again, that's a steroid injection, but there's also the possibility of using steroids. So if they're doing that, that can be a problem as well. So diagnosis, usually they're going to tell you, there's going to be some sort of injury, and so they're going to be able to tell you that they felt some sort of tearing or popping sensation with an activity. So again, this is usually a trauma. And so they'll say that they felt some sort of tearing or popping. And then after that, after they feel some sort of tearing situation, they're not going to be able to straighten their knee. So they're not going to be able to utilize their quadricep correctly. And they're not going to be able to weight bear on that side because the knee is going to buckle because, again, they cannot turn on their quadricep correctly. You can then palpate the tendon, the patellar tendon itself, again, distal to the patella, and they'll usually have some sort of irritability, tenderness, that kind of thing. With an x-ray, you're likely to see patella alta, which we'll look at here in just a second, meaning that the patella has moved proximally. So it's kind of moved up the femur in the trochlear groove. And then oftentimes they will use an MRI to confirm a diagnosis of a tear. As we've talked about before, MRIs are most helpful when we're going to do surgery to be able to say, okay, where is the tear? And it just helps prepare for surgery. So here's a good picture of, where the patella is supposed to sit with this patient and a little bit of knee flexion. And then you'll see that with a tear, how much further up the femur that is. So that's that patella alta, where the patella has now moved up, and you can see that pretty easily in an x-ray. This would obviously be a full patellar tendon tear where there is no more tendon attached, so there's no ability for the quad to kind of pull that patella back in place. Non-operative treatment is only used when it's small partial tears, okay? Very small partial tears. Again, the patella is still in place. We can then do non-operative treatment to really get that quadricep to contract eventually, so it's okay. We can still ultimately use the muscle. What they'll usually do with non-operative treatment is put them into some sort of immobilization with full extension, so again, putting that tendon in the best position to heal, and they'll put it in that position for a long time. So 6+ weeks, possibly, to again get that tendon to fully heal. And then you're slowly working on flexion range of motion. And that's going to be a big part of the rehab. And what we need to recognize is it's really, really important that we're going very slow. So this is the non-operative rehab, but then post-operative rehab, we're going very slow with flexion range of motion. We do not want to overstretch a healing tendon, okay? So after that immobilization and extension, you're going to slowly start working on flexion, and you're going to really, really, really focus on quad strengthening. So you are starting quad strengthening maybe even while it's immobilized. You're starting to get that quadricep to contract. And then after they're allowed to start doing mobility, you're really still focusing on quadricep strengthening. So most people are going to require surgery. Again, only if it's a very small tear will they do non-operative. So these surgeries need to be done early. I think we've learned that with pretty much every patient. There have been a couple of these different kinds of surgical candidates where we wait a little while for inflammation to go down or something like that. But most of our patients, the earlier we can do the surgery, the better. And so with this case, we're going to do it if there's a complete tear. We're going to do it if there's even partial tears that are larger tears where the quadricep can't contract. So again, that inability to achieve active full knee extension, they're most likely going to do a repair. And if you see that patella way up high in the trochlear groove or even out of the trochlear groove, more proximally on the femur, they're going to do surgery. So I'll show you in the next picture some pictures. The next slide, some pictures of the surgery. But basically, they're putting it's sutures that are put into through the tendon, and then they do these nice little bone, the bony like buttons, the cortical buttons in the bone. They drill holes into the bone, and they're basically putting the sutures between the tendon and the patella. Okay, so it's going into the patella itself. You want to make sure throughout the whole thing that the surgeon needs to make sure that patella is sitting in the exact right spot where it would be in a neutral extension position. And then they're going to hold that patella in position. They're going to put the sutures in, and they're going to usually add a little bit of extra tension to make it a little bit tighter. So you'll see here on the left-hand side that they have, this is a pretty basic one, so you'll see the little holes in the patella, the holes in the tendon, and then they're going to actually tighten that up pretty tight to make the tendon even maybe a little bit shorter than what it was initially. So they're going to make that tighter than what it was before the tear. And so you'll see on the right that this one, it's a little bit more complicated. Those sutures are a little bit more crisscrossed and crazy. And so that might be, you might see that the sutures are a little bit more in that kind of pattern than just the straight pattern like the picture on the left. It's the same thing. It really doesn't change our rehab. Just recognize that the tendon itself may be more shortened after the surgery than it was before the surgery. So that's obviously going to affect range of motion. Complications. The worst complication is going to be this last complication, which is this poor length tension ratio resulting in poor strength. So what that means is, again, when we talked about the surgery, that surgeon needs to make sure that there's good stability and there's good tension in the tendon with the repair. If it's not a tight enough repair, then that length tension ratio is not good. And so the contraction of the quadricep muscle and the movement of the patella superiorly when you contract the muscle is also not going to be very good. This also can be a complication that we, unfortunately, provide, that we actually cause. We can cause this length tension ratio problem ourselves with rehab. So this is the biggest issue that we have with this patient population, is unfortunately a lot of therapists think, oh my gosh, I have to get knee flexion, I have to get knee flexion, I have to get knee flexion. And so they end up overstretching the soft tissue, and we end up with a too overstretched tissue that will then decrease strength, decrease the ability for the quadricep to contract well, okay? So you have to be very careful with your knee flexion, and you have to work on getting knee flexion, and we'll talk about the timeline for that. But you are the ones who are going to cause these complications, oftentimes by overstretching, by over-focusing on knee flexion range of motion rather than focusing on quadricep contraction. Other complications that might occur, DVTs, infection. We see these a lot with any lower extremity situation. So that's not terribly surprising at all. Okay. Precautions. They're going to be using an immobilizer, so a big brace after surgery for a while. Usually they're going to do partial weight bearing because, again, we don't want a huge amount of strain put on. We don't want any strain put on the surgery site for a period of time. And then the big thing, as I've said before, this is the big thing you need to get out of this lecture: slow progression into knee flexion. Very slow. All right, so let's talk post-op. Our first phase is 6 weeks. And so it's a longer thing. It's definitely a longer period of time for that first protected motion phase than a lot of our other surgeries, but this is an important repair that we need to be kind of careful with. Our goals, as always, control pain and inflammation. We also want to make sure that the patella mobility itself is good. So again, we're not talking knee flexion, we're just talking patella mobility. So patellar mobilization, not knee flexion and extension. Here's our timeline for range of motion. At 2 weeks, we can get to 90 degrees, okay? That's the goal for 2 weeks, okay? Over the next 2 weeks, so by 4 weeks post-op, we can get to 110 degrees, okay? So actually, honestly, I think this is pretty reasonable for people in China. If you're getting your patients 4 weeks post-op, then you're okay with going past 90 degrees. The problem is that I worry that patients in China oftentimes don't see a therapist until maybe 4 weeks post-op. And so don't try to push it to 110 degrees because, oh wait, that's what the protocol says. If you are seeing them for the first time at 4 weeks post-op, you need to go just as slow as if you were seeing them the first week post-op. So what I mean is you're not going to say, oh, well, they're 4 weeks, I can get to 110. You're going to say, oh, I'm seeing them for the first time at 4 weeks. So I need to go slow. Maybe I'll get to 90 in the first week or two that I see them, and then work my way up to 110 in the third or fourth week that I see them. That's fine, okay? Don't try to push this. The other big goal is good quadricep activation. As we've said with some of the other surgeries in this module and other modules, straight leg raise with no extensor lag. If you can get that in the first 6 weeks, that's awesome. Again, it really depends on when you get to see them the first time. I think the idea of getting this in the first 6 weeks, if you're seeing them from week 1 or week 2, that's probably possible. But if you're seeing them at week 4 and you only have a couple weeks, you're not going to get there. So just really watch that and don't really work your way into the second phase until you can do this. Okay. Immobilizer, they're using it all the time because you don't want to overstrain the tendon that's healing. Okay. You also want to make sure that the surgical repair is protected. So, that's pretty obvious. Obviously, if you do too much flexion too early, the scar and the healing tissue is anterior, so you're going to have issues with the scar if you try to go do flexion too early. Too much flexion too early. So for our treatment, weeks 1 to 2, you're really doing, your normal modalities, and then you're doing that gentle range of motion. This suggests wall slides, which I think is fine if a patient can control a wall slide. With the wall slides, they're using mostly gravity, maybe a little bit of hamstring, but they need to be, again, just think of your person. Do they have good movement control? And if so, then this one works, the wall slides works fine. You are trying to get that quadricep contraction as early as possible, okay? As early as possible. The goal is to get that straight leg raise with some help during the first couple of weeks. Honestly, though, I'll be honest with you guys, I would not even do a straight leg raise during the first couple of weeks. I would just stick with quad sets. You can then also use NMES, but you're going to use NMES with a quad set, and then you can put something underneath the knee. So this picture, it's hard to see with this picture if the knee is in any flexion at all, but you can have some flexion. You're just not trying to do like a short arc quad yet because it's going to be too hard. You're really just kind of starting at 30 degrees of flexion and then pushing down. So you could use something like a towel or a pillow underneath the knee and just tell them to push down into the pillow. And while they're doing that, the electric stimulation is on. So we talked about NMES with other patient populations. We talked a lot about it with ACL repair. We talked about it with the lateral retinacular release at the knee. There's just a lot of good research to show that NMES can be really helpful for quadricep re-education. So it is highly suggested for this patient population. And so just, again, consider the positioning. You don't want to be in too much flexion, but you can be in a little bit of flexion. You also could do this in full knee extension. Okay, so NMES could just be in that quadricep, that quad set position, which is full knee extension on the bed. Week 3 to 4 treatment, again, continuing those modalities. We can get that range of motion to 110, like I said, but this is really only if you've been seeing them now for several weeks. Quad activation is a big thing. And then you can add the bike. So preferably a recumbent bike where you can get a little bit of a stretch. So you can maybe even just do like the half moons on the bike. So they're not going all the way around. They're just going to where they get a little bit of resistance and then they go the other direction. You also can start doing weight-bearing knee extension, so a standing TKE or total knee extension, or terminal knee extension, with some resistance is fine. It's really important that they can do weight-bearing knee extension as well as non-weight-bearing knee extension. This is something we talked about with ACL repair, and it can be true with other knee surgeries as well. They can get the knee extension on the table when they're laying down, but then when you have them stand up, they have a much harder time. So you need to be practicing it in both positions. And once they can do it pretty well in supine, then you definitely need to make sure they can do it in standing. You can also, during week 3 and 4, start doing some small squats. By week 5 and 6, we're increasing range of motion slowly. So 100, 110, maybe 115. And then we're getting our squats a little bit lower. So like kind of a half squat, maybe 45 to 50 degrees. I wouldn't really go much past maybe 60 degrees during these first 6 weeks. I know people don't really use Stairmasters here, but if you have the access to a Stairmaster, you can start doing that. You can start just doing stairs. That works too. And then you can move the NMES to like 45 degrees of knee flexion, so you can do more of like a long arc quad, but not from 90, just from 45. So a little bit more like a short arc quad, like so putting a foam roll or something underneath the knee, and then having them do extension from there. This is also when we can start doing more balance activities and things that require a little bit more control. So to progress out of this first phase, as we said before, straight leg raise with no extensor lag. So really making sure that they can get full knee extension, full quad set, hold that quad set through a straight leg raise. And you can see the picture on the left is showing extensor lag. So in that picture on the left, they're using their hip flexors completely. They're not using their quad. We never, ever want to see a straight leg raise that looks like that. Okay, that is not a straight leg raise. I'm not sure what that is. If you really want to work on that for hip flexion, that's fine. But if you're trying to get knee extension, that's not doing anything for their knee extension. So the one on the picture on the right obviously is a lot better. That's what we're looking for. Range of motion, like I said, 0 to 110 is a good place to be at the end of the first phase. Second phase goes all the way up to 12 weeks. So second phase is, you know, we're spending the first 3 months kind of being pretty conservative. And it's during the second phase that we can increase our range of motion. So remember, we're saying 125 degrees, which 125 degrees of flexion is somewhat limited for most people. We all know a squat toilet, you're probably going to need at least 130 for a squat toilet. But these patients do hopefully have a kind of a tight tendon. So, you know, these patients are going to be like, well, I want both my knees to have the same amount of flexion. That's not something that I would be pushing with this patient population. We're going to talk about Achilles tendon repairs, and I'm going to say the same thing with Achilles tendon. You do not want to have the same range of motion on both sides, because that might mean that you're not getting good quad contraction. If the surgeon was good, the surgeon might have made that tendon tighter. And if they made it tighter, then by stretching it out too much, because you want to have 140 degrees of flexion range of motion, you're going to end up with complications of the muscle. So I hope that makes sense. I would not push range of motion more than about 130 degrees. If they show you incredible strength and incredible knee control, then it might be okay. But I don't think it's worth it. I think it's much more important that you have knee control, not range of motion. And 130 degrees is probably okay to use a squat toilet. Second phase, ambulation without a brace. That's really what it is, because in that first phase, you're using it most of the time. The doctor's going to tell you how long they should use the brace when they can stop using it. And then our other goal is quad strength of 80% compared to the other side. If patients don't have heavy labor jobs, then they can basically go back to work at this point. And our treatment is really focusing on strengthening. And it's progressing your strengthening over the 6 weeks. So your squats are going to get a little deeper. You're going to do more of the stair stuff. So you're going to do things like step ups, maybe leg presses, single leg presses. And then we're increasing our proprioception. So when we're working on this stuff, we have to remember that different amounts of load is helpful for healing tendons. So, you know, we talk about, eccentric, which is great, but you should also be doing some concentric exercises, which you can certainly do with something like a leg press. You also should be considering things like active range of motion versus active assisted range of motion, because that's also going to put different amounts of load on the tendon. So be kind of creative with the different things that you're doing. Don't just focus on one type of exercise. You'll see pictures here. We have something like a step up. So again, step ups are going to be more concentric types of things. You'll see lateral. We could do lateral step up. So that's going to work on just a different angle of the tendon. It's also going to work on the lateral hip even more, which is great. But then we're also doing eccentric step downs. And eccentric we know is great. It's very important with tendons. And so when you are starting eccentric exercise, you're going to start. These pictures show the step with something underneath it. You're probably going to start with just the step and nothing underneath it. And you're going to start on this with the heel tapping to the side. So either the picture on the bottom left or the top right, that's how you're going to start your eccentric exercise. So it's going to be much easier to control from the side than it is from the front. So that picture, the bottom right, is showing an eccentric step down anteriorly. That's going to be a lot harder for them to do. So that's not where you want to start your eccentric exercise. To get out of phase 2 and into phase 3, you really want them to be walking normally. So you're looking for that knee extension during terminal stance and then allowing for good push off. And that's probably the biggest problem that we see. And then your strength, as I said earlier, should be greater, at least equal to or greater than 80% of the uninvolved side. So phase 3 goes all the way up until about 5 months. So this is a little bit slower rehab than some of the other ones we've seen, especially with tendons that are just getting debrided or released. So for this one, our goals are the range of motion greater than 90% of the uninvolved side. Again, I would say 90% is fine. Stick with 90%. We're happy with 90%, but strength definitely needs to be greater than 90%. So quadricep strength definitely needs to be greater than 90% of the uninvolved side. So we're doing a lot more single leg activities here. So single leg strengthening, possibly lunges, possibly single leg squats. Again, those eccentric step downs, single leg. Balanced proprioception activities are going to be progressed. Once the strength of the quad is greater than 80%, which is hard to measure, then you could start running. I would say I actually use the eccentric step down, the anterior eccentric step down that we saw in the picture. So the one where they're putting the heel in front. If they can do that off of a normal size step with good control and good alignment, then I would say they can start considering jogging. They also should be able to 2-foot jump, not hop. So hopping is 1 foot, but 2-foot jump really before they can start running. So I know this says that once strength is over 90%, that they can start jumping and cutting. Those are going to be like full-on 1-foot hopping or full-on jumping, lateral cutting, those kinds of motions. But for running, if they can just do a basic like jump off of a step or something like that, that's probably going to be your best kind of test to see if they can start running. So here's a couple pictures. We've got, some lunges here on the left, some sort of lateral lunges with some resistance on the right. So some different ways of training and getting, again, good alignment and good quad control. So sport-specific training starts, again, it's about 5 months later. It's hard to say what kinds of patients or people tend to have these tears. It could be an athlete who just pushed themselves way too hard and ended up with a tear. And so those are people that you're going to definitely be spending a lot of time doing sport-specific training. But oftentimes it could also be an older person who's not incredibly active And so you might be doing really basic sport-specific training or just kind of ADL training. So you may not be seeing them after the 5 months, but I would say you're probably going to see all of your patients up to about 5 months. Okay, that is patellar tendon repair.